So we're going to evaluate a patient today who's a 62-year-old man who presents with lower abdominal discomfort and rapid weight loss over a 3-month period. His past medical history is notable for hypertension and hypercholesterolemia managed by statin. He has palpable inguinal lymphadenopathy. From a diagnostic perspective, his absolute neutrophil count is 1,200. His platelets are 89,000. Both beta-2 microglobulin and LDH are elevated. Imaging studies by PET-CT scan reveals axillary and bilateral inguinal adenopathy. He has at least 5 masses measuring approximately 3 centimeters each. Biopsy confirms the presence of grade 2 follicular lymphoma. His FLIPI status is high risk. Bone marrow biopsy is positive, confirming Ann Arbor stage 4, and his ECOG performance status is 1. It is determined that the patient would proceed with therapy, and he receives 6 cycles of bendamustine in combination with obinutuzumab, to which he achieves a complete response. This is a patient who's generally not going to do as well as many of our other typical patients with low-grade follicular lymphoma, and we have to be thinking about alternative treatment strategies for him moving forward because it's anticipated that this patient is going to have a less favorable outcome. So FLIPI has been utilized for quite a while. Originally, there was the IPI, which was developed for aggressive lymphomas. And when that was applied to indolent lymphomas, such as follicular lymphoma, it didn't work particularly well because there was a small number of individuals characterized as high risk by IPI. So the FLIPI, which stands for Follicular Lymphoma International Prognostic Index, was created. And that looks at 5 variables, and those 5 variables include age, stage, LDH, number of nodal sites, and hemoglobin less than 12. The FLIPI was created, though, before the routine incorporation of rituximab to frontline therapy. And so the FLIPI-2 was developed after rituximab use was much more common, and it really looks at many of the same variables. Instead of looking at stage 3-4, it looks at bone marrow involvement. Instead of the number of nodal sites, it looks at whether any of them are larger than 6 centimeters. And instead of LDH, it looks at beta-2 microglobulin. Overall, I think they're relatively similar. And I don't so much use the FLIPI or FLIPI-2 to select therapy, but in some way it helps me think about what I might expect for outcomes for a patient following frontline therapy, and perhaps how I phrase it to them in my discussion.